Welcome to this essential guide on understanding and managing ectopic pregnancy. As a woman or a healthcare professional, it's crucial to be informed about ectopic pregnancy. Today we will explore the definition, etiology, clinical features, differential diagnosis, investigations, and management of ectopic pregnancy. Ectopic pregnancy is the result of a flaw in human reproductive physiology that allows the conceptus to implant and mature outside the endometrial cavity, which ultimately ends in the death of the fetus. Without timely diagnosis and treatment, ectopic pregnancy can become a life-threatening situation. The classic clinical triad of ectopic pregnancy is as follows: abdominal pain, amenorrhea, vaginal bleeding. Unfortunately, only about 50% of patients present with all three symptoms. Patients may present with other symptoms common to early pregnancy, such as nausea and breast fullness. The following symptoms have also been reported: painful fetal movements, dizziness or weakness, fever, flu-like symptoms, vomiting, syncope, cardiac arrest. The presence of the following signs suggests a surgical emergency: abdominal rigidity, involuntary guarding, severe tenderness, evidence of hypovolemic shock. Findings on pelvic examination may include: the uterus may be slightly enlarged and soft. Uterine or cervical motion tenderness may suggest peritoneal inflammation. An adnexal mass may be palpated but is usually difficult to differentiate from the ipsilateral ovary. Uterine contents may be present in the vagina due to shedding of endometrial lining stimulated by an ectopic pregnancy. Diagnosis involves serum BHCG levels. In a normal pregnancy, the beta-HCG level doubles every 48 to 72 hours until it reaches 10,000 to 20,000 milliliters. In ectopic pregnancies, beta-HCG levels usually increase less. Mean serum beta-HCG levels are lower in ectopic pregnancies than in healthy pregnancies. No single serum beta-HCG level is diagnostic of an ectopic pregnancy. Serial serum beta-HCG levels are necessary to differentiate between normal and abnormal pregnancies and to monitor resolution of ectopic pregnancy once therapy has been initiated. The discriminatory zone of BHCG is 1500 to 1800 mmU with transvaginal ultrasonography, but up to 2300 mmU with multiple gestates. 6000 to 6500 mmU with abdominal ultrasonography. Absence of an intrauterine pregnancy on a scan when the beta-HCG level is above the discriminatory zone represents an ectopic pregnancy or a recent abortion. Ultrasonography is probably the most important tool for diagnosing an extrauterine pregnancy. Visualization of an intrauterine sac, with or without fetal cardiac activity, is often adequate to exclude ectopic pregnancy. Transvaginal ultrasonography, or endovaginal ultrasonography, can be used to visualize an intrauterine pregnancy by 24 days post-ovulation or 38 days after the last menstrual period. An empty uterus on endovaginal ultrasonographic images in patients with a serum BHCG level greater than the discriminatory cutoff value is an ectopic pregnancy until proved otherwise. Color flow Doppler ultrasonography improves the diagnostic sensitivity and specificity of transvaginal ultrasonography, especially in cases in which a gestational sac is questionable or absent. Laparoscopy remains the criterion standard for diagnosis. However, its routine use on all patients suspected of ectopic pregnancy may lead to unnecessary risks, morbidity, and costs. Moreover, laparoscopy can miss up to 4% of early ectopic pregnancies. Laparoscopy is indicated for patients who are in pain or hemodynamically unstable. Differential diagnoses include abortion complications, appendicitis, cervical cancer, dysmenorrhea, early pregnancy loss, hemorrhagic shock, hypovolemic shock, placenta previa. Therapeutic options in ectopic pregnancy are as follows: expectant management, methotrexate, surgery. Expectant management candidates should be asymptomatic and have no evidence of rupture or hemodynamic instability. Candidates should demonstrate objective evidence of resolution, such as declining BHCG levels. Close follow-up and patient compliance are of paramount importance, as tubal rupture may occur despite low and declining serum levels of BHCG. Methotrexate is the standard medical treatment for unruptured ectopic pregnancy. A single-dose IM injection is the more popular regimen. The ideal candidate should have hemodynamic stability, no severe or persisting abdominal pain, the ability to follow up multiple times, and normal baseline liver and renal function test results. Absolute contraindications to methotrexate therapy include existence of an intrauterine pregnancy, immunodeficiency, moderate to severe anemia, leukopenia, or thrombocytopenia, sensitivity to methotrexate, active pulmonary or peptic ulcer disease, clinically important hepatic or renal dysfunction, breastfeeding, evidence of tubal rupture. Surgical treatment involves laparoscopy, which has become the recommended surgical approach in most cases. Laparotomy is usually reserved for patients who are hemodynamically unstable or for patients with corneal ectopic pregnancies. It also is a preferred method for surgeons inexperienced in laparoscopy and in patients in whom a laparoscopic approach is difficult. Thank you for joining us in this educational journey on understanding ectopic pregnancy. Stay informed and take proactive steps to safeguard your health.